Great. Okay, so welcome everybody. Thank you for being here this morning. It's really exciting to see such a large group today. We have a very exciting presentation to cover, and very happy to have Dr. Michael Lynch with us today. He is DDAP's substance use disorder medical consultant, and I will introduce him in a little bit here when it comes to his time to present some slides. So very excited to have him here today and to be talking about withdrawal management across the Commonwealth. So just a couple of reminders. I know a lot of you in the call right now have been in previous calls, but we really encourage people to submit questions on the topic that we're going to be presenting 7 days in advance of the call to the ASAM resource account. And so just for future reference, please, feel free to send those ahead of time. We didn't really get any questions on the topic of withdrawal management today. So we're going to be instead allowing some time at the end of the presentation just for open question asking on this topic. You can submit questions in the chat today. We will not be answering questions in the chat, but we will be referencing those questions when it does come time for question and answers. For the questions that we do not get time to touch base on, then we will be providing answers on the ASAM transition website in a Q&A document at a later date. Again, this call is being recorded. If you are not comfortable being recorded, please exit the call now. If you have suggestions for future topics, please submit those to the ASAM resource account, always looking for ideas on call topics. So a couple of disclaimers. So I think everybody on this call knows that alignment with the ASAM criteria is required for substance use disorder treatment providers that receive funding for providing treatment under agreements with single county authorities and managed care organizations. And we always like to really stress the importance of reviewing the ASAM criteria text in its entirety, attending the ASAM 2-day trainings, and reviewing the resources available on our website, particularly the training section of our website. So the information that we give you in these calls is just a snapshot. It's one piece of a much larger picture of the ASAM criteria. And so, in order to fully understand what we're talking about, you really have to understand ASAM in its entirety. Really, the only way that you can do that is by picking up that textbook, reading the textbook, attending some of the ASAM specific trainings. So just really want to stress that. Okay, so I just want to talk a little bit today about our rationale for discussing the topic of withdrawal management this month in particular. So over the past 6 to 9 months, a group of DDAP staff members have worked together to create a document titled the Guidance for the Application of the ASAM 3rd Edition Withdrawal Management in the Pennsylvania Substance Use Disorder Treatment System for Adults. So I know that's a lot, it's a mouthful. So this document is available now on our ASAM transition website. So you can kind of see, I have a little snapshot of that up here. And then you can see that it says new next to it. So our intention in creating this document was to really assist substance use disorder treatment providers across the Commonwealth in understanding how the various levels of ASAM criteria 3rd edition withdrawal management can be offered across a continuum of care. And when we're discussing a continuum today, we're not just talking about licensed substance use disorder treatment providers. We're talking about substance use disorder treatment providers who have partnerships with medical professionals. We're talking about non-licensed acute care, general medical, and psychiatric settings. So we're talking about a range of entities providing these services in partnership with one another. That's really what we're talking about when we're saying the continuum of care. And so ideally, in a perfect world, all of you on this call have had time to review this document that I'm talking about. And if you have not, I just really strongly encourage you to do so at some point and to also encourage your team members to do the same. It's a very helpful document and really kind of spells out a lot of what we're going to be going through today. It's a great reference. So our learning objectives today are really rooted in this document that we've created and in the conversations that DDAP staff have been fortunate to have with several medical providers across the state in the past couple of years. These are providers who are very much committed to improving the quality of substance use disorder treatment and particular withdrawal management. So we've been very fortunate to have these partnerships, these relationships with these medical providers, Dr. Lynch being one of them, who really helped us to kind of develop this document and help us understand withdrawal management better, especially in the Commonwealth. So in the first section, I'm going to be quickly reviewing some of the very basic tenets of withdrawal management as laid out in the ASAM text. We're going to be reviewing some definitions and some common themes across the 5 levels of withdrawal management. Then I'm going to be turning it over to Dr. Lynch for the remainder of the presentation, who will be reviewing substance-specific considerations in withdrawal management. So he's going to be reviewing considerations by substance, which is very much in line with ASAM's view that substance use, while it's a unitary condition, we have to acknowledge that withdrawal syndromes do vary based on pharmacological class of substance. And then obviously interventions will vary as well. So I want to make sure that we leave time today for questions for Dr. Lynch. So we're not going to be making it to this section 3 today, but I just want to make sure that you understand section 3 is really coming directly out of the ASAM text. And so it's really the overview of the 5 levels of withdrawal management. All that information is in the ASAM text. We also provide some really nice information about that in the guidance document that I discussed before. And just so you know that withdrawal management section of the ASAM text is on pages 132 through 143. So if you want to reference that at a later date or during the call today, that's where you can find it, 132 to 143. So as we've done in previous monthly CA calls, I want to call out some important definitions. I think it's important to note that withdrawal management encompasses both intoxication management and withdrawal management. You will also notice ASAM's attention to the word detox or detoxifies, and they really make it clear that the field is very much moving away from the term detox and using the term withdrawal management. So intoxication management obviously includes assessing level of intoxication and treating it appropriately. For example, if somebody presents as intoxicated with alcohol, you would ask a series of questions the best that you can, maybe gather corroborating information from family members or medical providers. If they're driving, you'd want to take their keys. You might want to give them a breathalyzer, and then you're going to monitor them for safety. So that person may or may not progress to symptoms of withdrawal. Withdrawal management, on the other hand, could include things like administering certain instruments to gauge severity of withdrawal, prescribing certain medications to ease withdrawal symptoms, maybe a physical exam, daily monitoring, treatment planning. It's going to be different based on each individual's unique needs and the level of withdrawal management that they'll require. So ASAM makes 2 things very clear in the withdrawal management chapter. Number 1, the goal is to really find the least intensive setting in which withdrawal management syndrome can be managed safely and comfortably. And then number 2, that the adult patient really, and this is a change in this version of the ASAM in this 3rd edition, the adult patient can really be engaged and continued in treatment that will lead to sustained recovery from substance use disorders. So we're going to talk about that a little bit more in depth in the next slide here. So an overarching theme, as I was just discussing in the ASAM withdrawal management chapter, is that withdrawal management is not just about treating the physiological symptoms of withdrawal management. We're no longer just paying attention to the physiological and psychological symptoms of withdrawal. Rather, we are interrupting the momentum of habitual and compulsive use, and we're seizing that opportunity to really engage the patient in the initial stages of treatment services. So withdrawal management can present a critical opportunity to break the cycle of use and to expose the patient to a supportive therapy and treatment environment. ASAM does make a clear point to acknowledge that because of how powerful that momentum is of habitual use, we know people have sometimes been using for years and decades. This phase of treatment often requires a greater intensity of services to establish that initial treatment engagement. And then across the 5 levels of withdrawal management, there are several themes that I'm just going to go through briefly here before I turn it over to Dr. Lynch. So in this edition of the text, ASAM really expanded the severity of withdrawal syndromes that can be managed safely and appropriately on an outpatient basis. So I think we all know that historically withdrawal management has been an inpatient procedure. However, because current medication protocols now allow all but the most severe withdrawal syndromes to be managed safely and effectively, we can really do this on an outpatient or an ambulatory basis. So that's a really major theme in this part of the textbook. And then in number 2, ASAM really drove home the importance of withdrawal management services being provided under a defined set of physician-approved policies and procedures. And I think it really makes sense, especially in looking at number 1. So ASAM really wanted to make sure that we were ensuring safety and optimal patient care. especially with this increased flexibility on the types of withdrawal that can be managed on an outpatient or ambulatory basis. And then in the remainder of these points, 3 through 8, we're seeing ASAM tenets that we've been talking about kind of nonstop in previous ASAM TA calls throughout almost the past year now. So individualized patient-driven care. What does the patient want and need? And are they involved in decisions made about their care? Ensuring that there is ease of access to higher and level lowers of care, and that transition and planning is occurring so that the patient doesn't experience any gaps or disruptions of care. This is of utmost importance, particularly for those folks who are coming from withdrawal management into non-withdrawal management levels of care. Families really need to understand what's happening to their loved ones during the withdrawal management process. How can they help? How can they monitor? How can they increase the likelihood that the patient is going to engage in treatment and support post-withdrawal management if that's what that patient needs? How can they get help and support themselves? And then as for patient education, talking about the medications that they're taking, some symptoms that they may notice beyond the official withdrawal management period, the role that nutrition, sleep, exercise plan in their recovery. These are all examples of the kind of things that we would be talking about and targeting as we're looking at these common themes. The fact that so I think one of the things that I also just want to mention here is that education about overdose potential post-withdrawal management is extremely, we all know that that's an extremely critical period of time where overdose is more likely to happen. So making sure patients understand that, making sure patients have Narcan, making sure patients know the steps that they can take to protect themselves against that, and family members as well. And then making sure that, because we are engaging the patient in therapies at this point in withdrawal management, if appropriate, then that we have a range of therapies that we can offer. So it's not just one type of therapy. It's not one size fits all. It's a range of therapies that are appropriate to what that individual patient needs. And then an interdisciplinary team. So especially with withdrawal management. So nurses, medical assistants, front office staff, security, counselors, certified recovery specialists, all working together and communicating about how that patient is progressing through withdrawal management is extremely critical. So obviously none of these themes are surprising because we've discussed these in previous TA calls, and they're present all throughout the ASAM text. So with that, I am going to stop talking now, and I'm excited to turn it over to Dr. Lynch so he can take a more in-depth look by substance into withdrawal management.
Okay. Thank you, Kathleen. Appreciate it. Hi, all. I appreciate the time to speak with you today. I'm going to go through sort of by, large substance categories, some things to consider with withdrawal management. I'm sure, given everyone's experience, you probably know a lot of this or have had experiences, and I think any of us who have treated patients for almost anything, and certainly within addiction, can understand that there's no one way to do it that's always correct, right? Every person has their own individual path, and that includes their treatment. But so we'll try to generally address some of the issues by substance, understanding that discussion wouldn't encapsulate every possible scenario that you could be faced with, and invariably there will be complexities that will require some creative thinking within the guidelines and associated with them. So we start with ethanol or alcohol, just because it remains the most common, by far the most common reason we evaluate patients for withdrawal management. In my practice, and statistics will tell you sort of across the Commonwealth. And one of the things, and we've innovated treatments for severe alcohol withdrawal, and done research and things like that. And one of the things that continues to be true is it can be very difficult to predict the severity of alcohol withdrawal. So if a patient presents and they haven't had a drink in a day and they're very tremulous, diaphoretic, their heart rate's really fast, and all those kinds of things, well, then they're probably having pretty significant withdrawal, and they could easily go on to have more, and that could be dangerous. Or if they clearly have a history of delirium tremens and those kinds of things. Or if the patient comes 2 to 3 days after their last drink, and that's pretty consistent, and they really don't have much, if anything, maybe some mild tremor, and that's it. It's also easy to predict, okay, they're probably going to be okay. But most patients present differently than that. Either there's still alcohol in their system, and we're trying to predict how likely it is they're going to have a severe withdrawal that's going to require medical management in the hospital versus outside, or some degree of alcohol withdrawal as they're coming off and trying to make those assessments. So it is difficult. Continues to be the most sort of consistent predictors of severe alcohol withdrawal syndrome are a history of severe alcohol withdrawal syndrome, more so than how much they're drinking each day. We know a lot of those things are subjective, not always accurate. Depending on the individual, they may over or underemphasize how much they're drinking each day. When their last drink was, it's not uncommon. I'll speak to somebody and they say, oh, I haven't had a drink in days, and their ethanol level is 350. Or they'll tell me I had a drink on my way in here and their ethanol level is 0. So those kinds of things can be difficult to use, though still helpful. When we try to use an objective scale, there is something called the prediction of alcohol withdrawal severity scale, or PAWS, that's been derived and validated and has performed better than other predictive tools. Lots of different things, different lab tests, phosphatidylethanol, things like that have been used. But as a scale, that has been used and validated. So that's one way that you can try to make a prediction that's reasonably accurate. Of course, there will always be outliers because a lot of the history is subjective. Then there's the CIWA, and you'll see withdrawal assessment scores as well, which is the CIWA where vital signs have been added. Those things don't predict severity of alcohol withdrawal, but they're helpful in assessing the degree of withdrawal at the moment that they're being implemented or employed. So that's a difference between those two scales. One is more predictive, and the other is sort of assessing what you're seeing right in front of you. Both have a lot of subjectivity to them. Neither is perfect, but definitely have, and the CIWA in particular has a lot of evidence behind its use, particularly in outpatient management of withdrawal. So if somebody is going to be managed as an outpatient for alcohol withdrawal, really regular assessments, employing the CIWA, seeing what the trend in response to treatment is, will be very important, because withdrawal from alcohol and other GABA agonists can progress despite appropriate therapy. And so regular assessments become important. But it can be done as an outpatient. So patients who don't have a history of severe withdrawal, they don't have a lot of complicating associated medical issues, can absolutely be managed as an outpatient, but that regular interaction and reassessment is key, as well as a lot of patient education and discussion. And of course, ASAM criteria don't only look at purely the medical need, but also are patients going to be able to follow through with regular reassessments? Do they have the ability to sort of connect or contact providers and give them updates on their progression? Are they able to come in to be reevaluated, daily in many cases in those early stages? All of those things sort of go into the decision of whether to manage somebody inpatient or outpatient. The management options, and I don't get into specific treatment algorithms for the different substances. In general, for alcohol, GABA agonists, so whether that be benzodiazepines or phenobarbital, both have very good evidence for their use, both inpatient and outpatient. Phenobarbital has a slightly more narrow therapeutic window, meaning the potential for toxicity is a bit higher, though most patients with severe alcohol withdrawal intolerance do tolerate both treatments quite well, and approaches about how much to prescribe, how much to provide a patient on day one versus reassessing and prescribing and tailoring to their response to treatment. I think that can be done in different ways depending upon comfort level of the treating physician and the program capabilities, for sure. But those, benzodiazepines and phenobarbital remain the evidence-based treatment for alcohol withdrawal, inpatient and outpatient, with differences in the protocols and how it's administered, depending on the environment where you're treating. It can absolutely be complex, alcohol withdrawal. We start with that because it does have the most potential risk, and really any GABA agonist withdrawal state has the most potential risk for medical complications from the withdrawal alone, meaning independent of other medical factors. Somebody can be apparently perfectly healthy and have life-threatening withdrawal, including seizures and delirium tremens. When those are present, or there's a strong history or any history of those things, consideration of inpatient management should be very high for those, because those are things that can't be safely managed as an outpatient. So lacking those histories of complicated withdrawal, would be part of making a decision to manage as an outpatient. Of course, in some patients, they've been drinking for years and years and never really have had a period of sobriety after heavy drinking to allow us to predict, and that can be more complex. And that's when we try to implement the scales, make decisions based upon our anticipated course and the patient's ability to adhere to that therapy. But with people who have a history of heavy alcohol use, co-occurring illness, nutritional deficits are very common, as I'm sure you all know. Often they are under-recognized and under-diagnosed because many patients with heavy alcohol use don't necessarily follow up with primary care physicians, may not have been diagnosed or had their chronic illnesses managed properly. And so those kinds of things can absolutely contribute to the determination for needing inpatient treatment, both for the withdrawal, but also to manage some of those co-occurring illnesses, certainly liver disease, but other unmanaged, whether it be diabetes, high blood pressure, those kinds of things as well. So those are part of the consideration for whether to manage as an inpatient. And nutritional deficits and need for vitamin supplementation and nutritional supplementation is nearly ubiquitous in patients with heavy alcohol use. Next slide, please. So this is the prediction of alcohol withdrawal severity scale, and I don't think it's in the ASAM. Primarily, it was really validated in the late 2010s, but it does have evidence behind it. And you can see, obviously, to be concerned about severe alcohol withdrawal, a patient has to have a recent history of heavy drinking. But beyond that, many of the questions have to do with a history of severe withdrawal in the past, as well as indications of really heavy drinking, including blackouts, things like that, that I think all of us are used to asking patients anyway. And this provides a scale. And then it does include a blood alcohol level, as well as early signs of withdrawal. So when you add all those up, a score greater than 4 indicates a risk for potentially severe withdrawal, greater than or equal to 4. So this is one way, at least something objective in a scenario where maybe it's a borderline case. Like any predictive tool or any tool in general, it is not, in and of itself sufficient. So, using some of your own clinical experience to make the decision as well is very helpful, but it does give us a good idea. So if the score is very low, that's encouraging for outpatient management. If it's very high, something that we would definitely consider, someone would consider doing inpatient management, particularly for alcohol. Next slide, please. The CEWA, I know this doesn't project very well. It's very small, but I'm also quite confident that most people are comfortable with its use. It's been around for quite a long time. Both subjective and objective findings consistent with alcohol withdrawal that give you a score. Again, important to remember that this is not predictive in any way. This is just a way to provide ongoing assessment of the severity of alcohol withdrawal. And typically, the scores will then have associated with them a dosing regimen, whether it be benzodiazepines or phenobarbital or other GABA agonists. A score of 10 or higher, associated with a certain dose, 20 or higher associated with another dose, in a really supervised setting, and otherwise something that can be done on regular reassessment, whether it's a day program or short daily visits, home monitoring, things like that. Next slide, please. So sedative hypnotics, the withdrawal syndrome of delirium, seizures, autonomic hyperactivity, so high heart rate, tremor, high blood pressure, sweating, flushing, certainly a lot of the other nausea, vomiting, anxiety symptoms are very, very much similar to ethanol withdrawal. The mechanisms are very similar. Alcohol does have some effect at NMDA receptors, so stimulant receptors that typically sedative hypnotic withdrawal does not. So it's not exactly the same, but clinically it can appear very similar. A lot of sedative hypnotic withdrawal syndromes, particularly things like alprazolam, can appear atypically, where you may not have as much autonomic hyperactivity. This is specific with alprazolam, but more of the delirium, confusion, some of those symptoms that go along with it, and can be longer acting. Whereas a withdrawal state for alcohol, typically from 3 to 5 days is what you expect for alcohol withdrawal. And typically by more than 5 days, you know that the physical withdrawal from alcohol has passed. With sedative hypnotics, it can be a bit shorter, but definitely much longer, depending on the specific medication or drug. As far as screening, Z drugs, so the sleep aids, are associated with misuse, tolerance, dependence, and withdrawal. Muscle relaxers like methocarbamol and carisoprodol are GABA agonists, so they can have very similar toxicity and withdrawal syndromes and tolerance and dependence as benzodiazepines. Things like etizolam and flubromazole are very common illicit or synthetic benzos that are not available as pharmaceuticals in the United States, but are definitely bought on the street, either as themselves or pressed to look like other medications, particularly alprazolam. And then GABA B agonists, and I think sometimes these are maybe overlooked. Things like baclofen. We're seeing more baclofen being used as a quote muscle relaxer, and often in an effort to avoid opioid therapy. Baclofen can have a lot of side effects, both in acute toxicity as well as withdrawal, and have very severe withdrawal syndromes that require ICU management. So regular heavy use of baclofen should be concerning for potential medically complicated withdrawal. GHB, which can be bought illicitly as well, and Phenibut, which is another GABA B agonist. And GABA B, just that receptor subtype compared to GABA A, exists in a different place on the nerve terminal. So the toxicity and the withdrawal can appear a little bit differently than GABA A, which is alcohol and benzodiazepines and Z drugs and those kinds of things. But generally from a high level, pretty similar, but long acting or long duration of withdrawal with the GABA B drugs, and definitely risk for complications. So heavy use and abrupt discontinuation of those often ends up requiring inpatient withdrawal management, as with other benzodiazepines and sedative hypnotics in high use with abrupt discontinuation. When we look at drug screens, in a basic urine drug screen, it's important to recognize that a lot of these sedative hypnotics, which place patients at risk for withdrawal, don't necessarily show up as positive. So all the GABA B agonists will not give you a positive on a basic urine drug screen. Z drugs, methocarbamol, carisoprodol, those kinds of things. The illicit benzos like etizolam and flubromazole may or may not give you a positive benzo screen. And I think many of us know that clonazepam specifically does not, or almost never shows up positive on a basic urine drug screen. In fact, that in speaking to a lot of patients, that's one of the reasons, even though it's longer acting and doesn't have the acute high, something like alprazolam sometimes is used in order to evade detection on drug screens. With confirmatory drug screens, sometimes specific chemical processes need to be done to confirm positive benzo screens, as opposed to sort of the typical approach. It really depends on the test. So gas chromatography mass spec may not give you a positive benzo even when it's there, whereas liquid chromatography with tandem mass spec or QTOF typically will show it. So then it just becomes more technical depending on the confirmatory drug test that's done. But most of those will find most benzos. And then the pathophysiology and risk is similar to alcohol withdrawal. A little bit more difficult to predict, I think, and especially because of the variability in the different drugs and maybe how much is being used. Using things like the predictive alcohol withdrawal severity scale and the CEWA, I think we do often sort of adapt those to sedative hypnotic withdrawal syndromes, and I think it's appropriate to do so, lacking anything else that's better, but understanding it's not exactly a direct comparison. So we often use doses and the degree of use of GABA agonists to predict potential for withdrawal, as well as a history of complicated withdrawal or presence of early withdrawal syndrome. So that threshold will be somewhat movable, obviously depending too on other co-occurring factors with the patient, and the withdrawal can be prolonged. So a typical inpatient withdrawal management of 3 to 5 days may or may not be sufficient depending on the medication or the drug that's being treated. Outpatient tapering with a lot of the benzodiazepines may require longer management, particularly if somebody's been on higher dose benzodiazepines for a long time and you want to taper them. That 3 to 5 day taper may be too short for a lot of benzodiazepines, which we end up tapering over several weeks or longer compared to alcohol. Next slide, please. So for opioid withdrawal management, we find that opioid withdrawal, while extremely, extremely uncomfortable, and I'm sure, again, many of you have spoken to patients or perhaps have experienced it yourself, but it's a really terrible thing to have to endure, going through opioid withdrawal. But in the end, rarely does it have associated life-threatening or medically dangerous complications. If a patient has co-occurring medical conditions, cardiovascular disease, history of seizures, things like that, it can place them at risk for acute exacerbations of those diseases. But the withdrawal itself, unlike pure GABA agonist withdrawal, is rarely something that requires medically managed inpatient management. Now, if they require inpatient treatment for other conditions, that's separate. But for opioid withdrawal, it's very commonly can be managed as an outpatient. Ideally, withdrawal management for opioids would be sort of coalesced with the ongoing treatment plan, meaning the withdrawal management should just be the very first step of the overall recovery plan, as opposed to sort of a separately considered process that once complete, then okay, now we transition to long-term rehabilitation and recovery management. And really, ideally, opioid withdrawal is recommended should be managed with opioid agonist therapy, just because long-term opioid recovery should generally be managed with opioid agonist therapy, or at least offered in most patients. Therapy with something like naltrexone absolutely has evidence for its success and should be considered while in discussion with the patient. So there should be shared decision-making regarding the long-term treatment plan as it relates to what the approach and strategy will be for withdrawal management. So if somebody is anticipating naltrexone therapy, or if they're going to try abstinence-based therapy, despite its obviously inferior outcomes overall across the board, the management for their withdrawal would be different than somebody who will likely be on long-term agonist therapy. So if somebody may or may not or is unsure, typically we would start with buprenorphine as an outpatient, just because that can be started quite quickly, can be prescribed. It's important to recognize that both ASAM and the National Academy of Medicine recommend that initiation of medication therapy for opioid use disorder, including management of withdrawal, should not be delayed while completing intake assessments, behavioral therapy evaluations, and so forth, given its significant impact on reducing likelihood of overdose death, both short and long term. So typically it's going to be buprenorphine. Methadone certainly can, though the ability to get somebody up and running in an opioid treatment program very quickly on the day that they present, which is when this should be initiated, that can make things difficult. Fortunately, it is easy to transition from buprenorphine to methadone therapy. So even if somebody's long-term plan is going to be methadone, initiating withdrawal management with a buprenorphine therapy, and by buprenorphine therapy, I don't mean a tapering dose. I mean starting an induction followed by a maintenance dosing, and then transition to long-term maintenance. But if that plan is going to be methadone, based upon assessment of the patient, their desires, their needs, their response to treatment. Buprenorphine transition to methadone is not medically difficult. The vice versa, methadone transition to buprenorphine is more complex and technically difficult, though certainly possible. If a patient is planning to, after discussion of all available options, including naltrexone, buprenorphine, methadone, with abstinence-based therapy being a much lower recommendation. If their plan is going to be abstinence-based or naltrexone, then withdrawal management with using a COWS score and non-opioid therapies. And they vary, but typically are some combination of things like clonidine, hydroxyzine, loperamide, and a nausea medication, something for anxiety relief, typically not benzodiazepines, occasionally trazodone for sleep. Things like that can absolutely be used, though withdrawal improvement is inferior with those medications compared to an opioid agonist like buprenorphine. So using the Clinical Opioid Withdrawal Scale, or COWS, and then also there's a Clinical Institute Narcotic Assessment, or CINA scale, will help to identify the degree of opioid withdrawal, and we'll look at those in a sec. And for outpatient management for buprenorphine, so in some cases, and we'll talk a bit about this, but buprenorphine induction, specifically because of the pharmacology of buprenorphine as a partial agonist, we probably all know that the primary risk for initiating it is precipitated withdrawal. So if an individual comes in, is interested in management of opioid use disorder, and has a history of regular use, tolerance, dependence, but is not yet in any opioid withdrawal, we can anticipate and predict that the patient will experience opioid withdrawal. And we also know that opioid withdrawal is a significant risk factor for returning to use of opioids, especially in early recovery. I'm not sure what happened to the slides, but I'll just keep talking for now. You will still want to initiate medication treatment in anticipation of development of opioid withdrawal. So if a patient doesn't have active withdrawal at the time of our initial evaluation, typically what we recommend is discharge or prescription for outpatient home induction of opioid withdrawal management. And so one of the things that we can use to help patients sort of guide themselves through that induction, in addition to support from peers and other providers and reassessment at an outpatient program, is something called the Subjective Opioid Withdrawal Scale, or SOWS, which really looks a lot like the COWS, but something that people can mark down their own scores and kind of keep an idea so that you can provide recommendations at a score of, say, 10 or 15 or 17, I've seen, you can start with initiation of medication. Often with buprenorphine, there are a lot of different induction sort of processes and pathways, often that start with low doses or even quote unquote micro doses, to try to minimize the amount of withdrawal somebody needs to experience before they're able to start their buprenorphine. That's sort of a lecture all in and of itself. So I'm not going to cover all the different induction pathways, but really key that we want to avoid precipitated withdrawal, because we don't want that to be a reason that somebody is lost to follow-up or loses faith in the treatment process overall. But we want to use that withdrawal management as just the first step in a continuum of treatment, whether it be in different programs, different facilities, different environments, et cetera. We want that transition to appear smooth, so it's not separated withdrawal management from overall recovery. Next slide, please. So this is the COWS scale and the CINA scale. As you can see, a lot of opioid withdrawal, as we know, much of it is very subjective. Patients, I think we've all seen this, can be feeling terrible, and while they look uncomfortable, it can be difficult objectively to determine the degree of withdrawal they're in. Things like piloerection or goosebumps, with sweating, nausea, high heart rate, active vomiting, and diarrhea, all being things that can be observed that are indicative of withdrawal. I will say one important thing to recognize is, given the degree of co-occurring use of stimulants and opioids, acute stimulant toxicity and opioid withdrawal can appear quite similar. And I have definitely seen patients who appear to be in opioid withdrawal get buprenorphine and then have also precipitated opioid withdrawal because the last use of opioids have been very recent. So we typically like to see people not having used opioids in at least 12 to 24 hours for buprenorphine induction, in addition to objective symptoms. Next slide, please. Fentanyl, I call it out specifically, one, because I think we're all very well aware that fentanyl is everywhere. Where I practice in southwestern Pennsylvania, we haven't had heroin in years. I mean, it's out there, but heroin without fentanyl has been sort of a unicorn for us for years. Starting in 2014, 2015, we're seeing more and more fentanyl on our streets, lots of variants and analogs. And that has continued. And I think we're also well aware that other stimulants like cocaine and methamphetamine have been found to have fentanyl within them. Patients who only use stimulants or swear they haven't used anything else will come with acute fentanyl overdoses after using what they thought was cocaine. Fentanyl powder pressed into pills to look like either prescription opioids like oxycodone or like prescription sedatives like alprazolam. We've seen both. And you can imagine somebody who maybe is buying pills to avoid fentanyl, particularly if they're not buying opioids, running into problems with fentanyl. But for the purposes of withdrawal management, important to recognize that almost everything is fentanyl. Withdrawal management is essentially the same. However, it has been the experience of many treatment providers that patients who've been using primarily fentanyl, particularly heavily, even when they're experiencing withdrawal symptoms, and it's been 24 to 48 hours since their last use, which traditionally would be perfectly safe to do buprenorphine induction, will still have some degree of precipitated withdrawal if they're started on buprenorphine at doses like 4 or 8 milligrams. So many protocols now with buprenorphine induction include some type of low dose or quote unquote microdose induction, particularly because of the prevalence of fentanyl. So something important to remember and take into account with our withdrawal management pathways. Next slide, please. This is just a visualization of the subjective opioid withdrawal scale. So kind of simple questions that are in layman's terms that people can answer and score themselves, as well as some guidance at the bottom of what constitutes mild, moderate, and severe withdrawal. So this can be helpful as part of an outpatient induction protocol, which has been studied and shown to be very effective for patients with opioid withdrawal management. Next slide, please. Cannabinoids, including marijuana, we've seen increasing use of synthetic cannabinoids throughout Pennsylvania again, since maybe 2014, 2015, when they really hit hard, appear to have stimulant toxicity effects when seen in acute use, again, with synthetic cannabinoids or really highly concentrated THC products. There is withdrawal from regular heavy use, but it's primarily subjective, mild physical manifestation, some shakiness, sometimes sweating and anxiety. But things like seizures, delirium, really severe withdrawal would not be anticipated. Management of withdrawal is really just with supportive care, symptomatic treatment for the cannabinoid withdrawal symptoms. Next slide, please. Stimulant use also on the rise, particularly methamphetamine. We've seen increasing utilization throughout Pennsylvania. Cocaine use has always been quite prevalent, but we've seen an increase in the amount of cocaine present in overdose deaths and being used often in combination with other drugs, including opioids. Withdrawal, so acute toxicity is the more dangerous part of stimulant use for sure. So acute toxicity with agitation, potential for seizures, cardiac rhythm problems, and bleeding in the brain, traumatic injuries, muscle injury and breakdown. All those types of things are much more risky and dangerous to the patient. So managing that acute toxicity, differentiating it from a withdrawal syndrome, does take some clinical expertise and experience, with the primary treatment for acute toxicity being sedation, usually with benzodiazepines or other sedatives, and antipsychotics like haloperidol, for instance, or droperidol are commonly used. But for withdrawal, Typically, what we'll see, sometimes people will hear the term cocaine washout, or after heavy stimulant use, when people stop using, usually what we see is just sort of sedation, like really like lethargy, just tired. People don't stop breathing. Typically, they don't have any cardiovascular issues. It's really this, that they're worn out, essentially. Their bodies are worn out. So again, not a withdrawal syndrome that typically requires a specific medication management. Supportive care, a lot of behavioral and social supports are necessary. But as far as medically managed withdrawal, nothing that would typically be expected to require hospital-based inpatient management. However, the complications of recent use should be evaluated and those potential issues identified to ensure that there aren't residual cardiovascular effects or muscle injury or kidney injury or traumatic injuries from recent stimulant use. Next slide, please. And xylazine. So a lot of discussion about xylazine lately, in particular, over the last couple of years. Xylazine has been something that has been an adulterant in heroin, cocaine for the last couple of decades. I remember training as a resident and fellow, and we would find this in heroin products every now and then, pretty infrequently. We used it. I used it in animal studies that we ran, when I was a fellow looking at drug toxicity. So xylazine works in the body the same way that medications like clonidine or lofexidine do, or dexmedetomidine, brand name is Precedex for that. It's what's called an alpha-2 agonist. And so the way that it works is typically if you take, and we'll use clonidine as an example, just because it's been around for a very long time. If we take oral clonidine or crush and snort it, usually what will happen is briefly you'll get a peripheral effect. So, the peripheral nervous system, you'll get squeezing down of the blood vessels. So your blood pressure might go up temporarily, but then as it gets absorbed into the brain, the way that it works in the brain is it blocks those sympathetic or stimulant outflows from the brain. So everything slows way down. People are sedate, their pupils get small, their heart rate goes down, their blood pressure goes down. With enough of it, any alpha-2 agonist, it can slow down breathing. It does not work on opioid receptors, though alpha-2 receptors and what are called imidazoline receptors do overlap with opioid receptors in their overall pathway for reward and sedation. So while they don't work on opioid receptors, they are sort of related or associated. So naloxone reversal has been reported for things like clonidine toxicity, like in children, though it's not consistent. So, but because it doesn't really work on opioid receptors, wouldn't expect a significant reversal from naloxone on xylazine. But where we see it now is adulterating fentanyl products, particularly in Philadelphia. All over Pennsylvania, we see this in Pittsburgh as well, but Philadelphia has really seen a lot of xylazine adulteration. And so, in the acute phase, it's synergistic with an opioid or fentanyl, causing sedation as well as respiratory depression. So it does increase acute overdose risk. I presume that the reason that it's being used, in addition to being a bulking agent, but that wouldn't be the only reason to use it, because there are a lot of those that don't cause any adverse effects. But probably because that sedating sort of synergistic effect would be expected to last a bit longer than the fentanyl effect. So it might provide a bit of, quote unquote, a tail after that acute up and then down of the fentanyl, just so that patients don't experience that really abrupt high and low of typical fentanyl use. I suspect that's why it's being placed in the fentanyl. Many of you may have heard that the street name for this is quote unquote tranq, for tranquilizer, with fentanyl and xylazine. But what's being reported, especially by our colleagues in Philadelphia, where it's much more prevalent, I think last year something like 40% of overdose deaths with fentanyl had xylazine also identified. Is it's associated with wounds that are being reported, both at injection sites, but also distant from injection sites. So presumed not to be just from needle entry. And this had been reported previously in Puerto Rico, where xylazine had been more prevalent 10 years ago. And it's not really clear why this happens. It might have to do with the blood flow and that initial constriction of blood vessels I talked about. Xylazine itself isn't a toxin that should cause skin toxicity. And it's not a generalized skin problem. It's usually isolated wounds that are risk for infection. So wound care is really important in evaluating for wounds, both from injection as well as potentially related to xylazine. Management is the same with typical local wound care and antibiotics if needed. And then withdrawal from xylazine has also been reported. So much like people who are on clonidine and medications like that, say for blood pressure, over a long period of time who abruptly stop those medications, that blockade of the adrenergic or the sympathetic stimulating tone from the brain, if you take that away suddenly, then all of a sudden people will have an overflow of, so their high heart rate, high blood pressure, sweating, tremor, anxiety, those kinds of things, which can overlap quite a bit with opioid withdrawal, as well as say like alcohol or other GABA agonist withdrawal, but wouldn't really be expected to respond well to say like buprenorphine or opioid therapy or other non-opioid withdrawal management strategies. Recommended would be things like clonidine and lofexidine, which have traditionally been used for opioid withdrawal symptoms, but those work on the same receptors as xylazine. But it has complicated withdrawal and really severe withdrawal. Those medications, those oral medications, may be insufficient, and patients may require stronger sedatives, benzos, barbs, or even admission with things like dexmedetomidine infusions, which is an IV sort of medication that's similar to this that we use for sedation, particularly in pediatric anesthesia. So xylazine is something that I think we're still trying to understand the breadth and scope and severity of its presence, but clearly the prevalence has increased quite a bit, especially in eastern Pennsylvania, where both in acute toxicity and ED-based management, but also in withdrawal management facilities, I know have had to deal with this complication. So other things to consider, particularly in the eastern part of Pennsylvania, that we're seeing it everywhere. Next slide, please. I think that might be it from my slides.
Yes, Dr. Lynch, thank you so much. So we have about 7 minutes left. If anybody has any questions for Dr. Lynch, he would be happy to answer those. And if you want to raise your hand, you can either type your question in the chat or you can raise your hand and I can unmute you. Okay, I see a question here. Let me see if I can pull this up. Paul, you should be able to unmute yourself now.
Thank you. Yeah, I did put this in the chat as well. My question is, if I have a client who is already active in an outpatient or IOP program, but has been continuing to use and is moving to a point where they're ready to discontinue use, and we're looking at an ambulatory withdrawal management, can they continue in the same IOP outpatient protocol while simultaneous with doing the IOP? Or I mean, simultaneous with doing the withdrawal management? And maybe this is a question for managed care. I don't know.
Yeah, that I'm probably the best person to answer that. Medically, it's perfectly appropriate, but from a regulatory and payment perspective, I'll leave that to others to answer more specifically.
So does DDEP have an opinion on that?
I think Kathleen is frozen.
Yes. Hi, everybody. Sorry about technical difficulties this morning. Did we answer Paul's question yet or no?
No.
Yeah. So Paul, without knowing all the information about the individual patient, I would say absolutely. I mean, I think that's kind of what we're trying to really transition to here in our system in general, is this idea that withdrawal management is no longer just a period of time where we're treating those physiological symptoms. If the patient is ready, we're starting to engage them in other therapies as well. It is really an opportune time to do this. Obviously, I know that there are payer, potentially reimbursement issues that might need to be addressed.
Right.
But in terms of clinically speaking, absolutely, yes.
Okay, thank you.
Yes. what else do we have here? I think I saw somebody else had their hand up. Let me just pull this up here.
While you're doing that, there's one in the chat from Elika Shah. As far as withdrawal management protocol related to methamphetamine and other stimulants, I think that, again, from my perspective, from a medical perspective, it's really going to be subjective and symptomatic supportive care. We typically aren't needing to do sort of tapers of stimulant drugs. As far as medication management long-term for stimulant use, of course, that's a topic that continues to be studied, looking at things like bupropion, naltrexone, et cetera, though none that are clearly effective in all populations. But as far as withdrawal management, we don't really see that as being necessary. So I think it's really just going to be a matter of that individual patient, particularly whatever else may be associated with their recent use, other substances being used, et cetera. See a lot of patients with co-occurring stimulant and opioid use who seem to have benefit of both use disorders with good management of their opioid use disorder, even though the chemistry is completely separate as far as recurrent use, but that's not always consistent and more anecdotal. But as far as specifics to the methamphetamine use and other stimulants, I think that it's just got to be tailored to the individual symptoms and what they're experiencing. But I don't think there's one specific protocol that should be employed for each one, or you'd be at risk if you did not employ. Maybe it would be a better way of looking at it.
Other questions?
How is the transition from methadone to Sublocade? Does Sublocade have the blocker that buprenorphine does? Yes. So buprenorphine is itself a partial agonist. So when we think about the blocker, and a lot of patients get confused about this, understandably, right? When they see the term naloxone, they think blocker, dangerous, that puts me into withdrawal. But when people have precipitated withdrawal from, say, Suboxone, we'll say it has buprenorphine and naloxone in it, it's not the naloxone that does it, unless they inject it, which I'm sure they're not. It's the buprenorphine itself. So the buprenorphine, which is present in Sublocade and injectables, can have the same risk of precipitated withdrawal. The only real way to get onto an injectable buprenorphine is to have started sublingual anyway. And transitioning from methadone to buprenorphine, because of how long-acting that methadone is, it is a process. Again, there's a lot of microinduction pathways with really tiny doses, or even transdermal buprenorphine that we can use to facilitate doing that more safely. But there's a lot of different ways of doing that, not one clear right way. But you'd want to transition to sublingual and then to injectable buprenorphine, both to make sure that they tolerate it well, but also because of that potential risk of precipitated withdrawal.
Great, thank you, Dr. Lynch. So I think we're about out of time right now. If you have questions that we were not able to get to today, please feel free to send those to the ASAM resource account. We are happy to touch base with Dr. Lynch and get you a response back. So please feel free to do that if we were not able to get to your question today during the call, or if something kind of pops into your mind after we get off the call today. So I just want to say a great big thank you to Dr. Michael Lynch today. Thank you so much for presenting. This was such an informative presentation. Before we sign off today, I just want to let people know that the next ASAM TA call is going to be on Monday, October 3rd from 10 to 11. So Monday, October 3rd from 10 to 11. And the topic, it's going to be a pretty quick turnaround, but we are going to be talking about ways to approach individualizing daily programming or daily therapy schedules in the treatment setting. So I think it will be really helpful to providers who are transitioning to ASAM. And if you have questions related to that topic, you can please send those to the resource account, and we can make sure to address those during that next call. Again, thank you everybody for being here today. Thank you again, Dr. Lynch, and we'll hopefully see you next month.
Thank you all.